Hello, everyone. You can take your seats. So welcome to the second annual Whole Communities Whole Health Research Showcase. And you can see we chose a really large venue, so you can feel free to social distance if you want and feel comfortable within the room. I'm just going to give a quick overview of the agenda. We did have to flip-flop a little bit today based on our keynote speaker flying in and her flight. So we'll be starting the day with a selection of kind of flash science talks. So we'll have about 6 minutes for each of those talks, including questions, so they'll be kind of quick. After that, we'll take a short break, and then we'll go into our keynote speaker will be here. And then following the keynote speaker, we'll have a little reception and mingling out with some refreshments, so you can have time to speak with the keynote and all of the wonderful flash science presentation speakers this afternoon. So without further ado, we'll jump in and start the day. So I'd like to first introduce Jennifer Lyon Gardner, who is the Deputy Vice President of Research in the Office of Research, Scholarship, and Creative Endeavors here at the University of Texas. And she'll be presenting and starting the day. So welcome, Jennifer.
Hi, good afternoon, everybody. Welcome to the Whole Communities Whole Health Research Showcase. I'm really excited that you're here with us as we highlight the work that this Grand Challenge research team has done over the past year, and really since its inception. As this past year, we've reached this major milestone of launching our community cohort study. So I wanted to start by briefly telling you the origin story of the Whole Communities Whole Health Research Challenge. UT Austin started envisioning a Grand Challenges research initiative in the spring of 2016, which was about 6 years ago now. The vision was to define ambitious yet achievable goals that leverage our university's interdisciplinary research community to address real-world, urgent problems. My office had asked our faculty and research community to bring us their ideas for what kinds of complex research issues they would like to explore across the disciplines over the next decade. We received more than 100 concepts from more than 800 faculty and other senior-level researchers across campus. From there, we introduced researchers who had unknowingly submitted related concepts to each other and asked them to work together over the spring and summer of 2017 to converge on a shared Grand Challenge goal. From the group of 50 or so researchers that's now known as the Whole Communities Whole Health Grand Challenge, that goal was to understand and support individual thriving with an emphasis on both equitable community engagement and smart technology. Equitable community engagement and smart technology. Those two things have a natural tension. Technology allows us to collect a lot of data. The tension is in discerning what we should collect from what we can collect. We discern this by working with our community and researchers to refine the research questions and also to understand what we need to answer those questions. Whole Communities Whole Health researchers also have worked to relieve this tension by putting participants' privacy at front of mind, which might make us change the way that we collect data, not send raw values for GPS, for example. Another goal of the Whole Communities Whole Health Grand Challenge is to fundamentally redesign the longitudinal cohort study model so that it's more accessible and therefore more representative of a diverse participant population and the dynamics in which those participants live their daily lives. The Grand Challenge team has taken an iterative approach that makes use of community input, focus groups, and pilot studies, several of which you'll hear about in a few minutes in lightning talks, to understand how to ensure that we are including a diverse participant population. I want to highlight just a few things that we've done, the progress to date, before we continue on with the program. First, we've forged some extremely strong, meaningful partnerships with the Central Texas community. Whole Communities Whole Health has a community strategy team whose strong voices guide us, and we also partner with organizations like the Community Coalition for Health. Most recently, we partnered with our own School of Nursing to support mobile vaccination clinics in eastern Travis County. We've also spent the past 3 years designing, developing, and testing devices and methodology for data capture for our cohort study. The first iteration of that technology was deployed in our UT1000 and UT2000 studies in the fall of 2018 and the spring of 2019, respectively. The UT1000 study focused on wearables and smartphone apps to collect data. Then UT2000 folded in environmental beacons. Through those studies, we learned where we needed to make modifications to the beacons, and we also verified that the data pipeline, the wearable tech, and the app-based technology all were robust, as roughly 1,000 participants were kicking the tires on all of those components. The Grand Challenge team published work on the ability to predict loneliness from smartphone-based Bluetooth and GPS measurements. In the spring of 2020, the Grand Challenge team rolled out one final study with college student participants, one that integrated everything that we've got so far in tech: beacons, wearables, environmental sampling, biological sampling. Coincidentally, that study wrapped up right as our campus was forced to close at the start of the COVID-19 pandemic, which actually created a unique opportunity. We were able to re-enroll the study participants for a follow-on period from May to August 2020, and then publish a report that looks at pre- versus post-COVID mobility pattern changes among that group. The researchers also presented findings on indoor air quality and its effects on sleep quality for that same group. Other research you'll hear about today includes a study for sensing daily activities such as child-caregiver interactions, as well as a study that gamifies physical activity in schools. They're all impressive findings and great milestones for sure, but the biggest milestone to date was achieved in August 2021 when, after more than 3 years of working with Central Texas communities and piloting methods and technologies, the Whole Communities Whole Health Cohort study officially launched when our first Central Texas family enrolled. We currently have 15 families that we call our ambassador families enrolled in the study, and we're gathering families interested in participating for a cohort enrollment that'll start very soon. We've also been expanding our recruitment efforts to interface with more schools, more child care providers, and clinics in our area. It's really exciting for me to have witnessed the progression of this theme from a collection of 2-page concept papers to a full-fledged cohort study that's drawing in scholars and research expertise from nearly every college and school on the UT campus, all for the benefit of the region where we work and live. I'm glad everybody's here today to help us celebrate the group's accomplishments with me. So with that, I will turn it back to you, Carla.
Thank you. So we will start the lightning talks next, and each lightning talk will end with a question and answer session. And you should see a roving microphone in the audience. If you'd like to ask a question, just raise your hand or stand up, and that person with the microphone can find you. We are taping this, and so it will be available and recorded if you'd like to watch at a future date. So we would love to have you on the microphone when you ask questions, because that will make for the best recording. So without further ado, I would like to invite Melissa Miller to the stage.
All right, this is going to have to come down because I'm short. Okay, can you hear me? All right, so yes, thank you for having me here today. So today I'm going to talk about some interesting research that we conducted prior to and during the COVID-19 pandemic. So I first became interested in stress research through stress-related disorders such as PTSD and depression. And early on, I realized that in order to better understand these disorders, it was important to better understand the role of chronic stress in the development of these stress-related disorders. Stress is often categorized in two components, the perceived stress component and the physiologic response component. In my research, I will describe these as psychological stress and biological stress. Chronic psychological stress is often measured using traditional stress surveys that assess stress retrospectively over the past month or several months, and so are typically associated with recall bias. Chronic biological stress is often measured using hair cortisol concentration because hair cortisol is known to reflect long-term cortisol output. And the challenge here is that these two are often presumed to be correlated. So chronic psychological stress is often presumed to be associated with chronic biological stress, and the association between these two variables is often inconsistent in the literature. And so this is possibly due to the recall bias associated with the traditional stress surveys that I talked about. So the goal of the research that I'll be talking about today is to assess whether a more accurate and real-time measure of stress is a better predictor of hair cortisol concentration or biological stress. So to measure psychological stress, we use the Perceived Stress Scale, or PSS, and we adapted it to measure, to assess stress on a weekly basis. And so we used this survey and administered this survey once a week at the end of the week on Saturday. And this survey, the responses for this range from never to very often. And this I'll refer to as my PSS measure, or PSS score. This was our measure of real-time stress. So we used Ecological Momentary Assessment, or EMA, to measure stress using a one stress question in which participants were asked how stressed they were feeling in that moment. And responses for this stress question range from not at all to very much. And this survey was administered several times a week on the days that you see here, both in the morning at 7 a.m. and then in the evening at 7 p.m. And this I'll refer to as my EMA stress measure. In order to measure biological stress, we use hair cortisol concentration, which again is known to reflect long-term cortisol output. And chronic psychological stress, again, is often presumed to correlate with hair cortisol. And the association between these two variables is often inconsistent in the literature, with some studies showing an increase and other studies showing a decrease or no relationship at all. The figure here shows that hair cortisol, the closest centimeter of hair to the scalp, reflects the previous month of cortisol exposure. And that's why we're using this measure as our biological stress measure. So this shows the timeline of our procedure. So from January to March 2020, we recruited UT students, and these UT students answered the weekly PSS survey as well as the EMA stress question survey that was administered several times a week. And at the end of this first study period, a hair sample was collected, again to test the relationship between EMA stress and hair cortisol concentration. Interestingly, at the end of this first study period, the COVID-19 pandemic began in our area, as Jennifer mentioned, and so we were able to re-recruit a subset of these same participants for a second wave of data collection from May to August of 2020. And they again answered the PSS survey questions and the EMA stress questions on the same time scale. Oh, sorry. And then at the end of the second study period, we collected another hair sample. And so this allowed us to test some group differences in these stress measures. And so I will refer to the first group as the pre-group and the second group as the post-group in this talk. So first I wanted to test whether our EMA stress question data was correlated with our PSS survey data, because the PSS survey is a validated instrument. And so I tested whether the average weekly stress for a given individual was correlated or associated with their PSS score, and found a significant positive association between these two. And so this was encouraging because it showed that our EMA stress question reliably assessed perceived stress in these individuals. This shows some group differences in EMA stress on the left and hair cortisol on the right, with the pre-group in orange and the post-group in the gray-black. And I did find significant group differences in EMA stress between the two groups, such that the post-group showed a lower average EMA stress than the pre-group. And as far as hair cortisol, I did not find any significant difference between the groups. However, I still have another batch of hair samples that I need to process, and so I'll be rerunning this analysis again. So this shows some sex differences in EMA stress, again on the left, and hair cortisol on the right. And females are in the red, males are in the blue. No significant differences here. And I'll go ahead and move on to the next slide since we're going short on time. So this is the last slide that I have to show. This shows me testing my primary research question of whether our real-time measure of stress was significantly associated with the hair cortisol concentration. And while the mean stress for a given individual was not significantly correlated with their hair cortisol concentration, when I tested females only, I did find a significant association. However, I still need to do some model validation. And thank you for your time, and to everyone on this slide, and yeah, thank you. Any questions?
We probably have time for one quick question. Carrie.
So if I interpret your data correctly, basically the pre-group was more stressed out. In other words, being in school is more stressful than being at home from May to August. Is that correct? Is that what you're?
I can't say that that's the cause of it, but you know, the effect that we saw could be due to the time of year being
Yes.
the academic, summer months, or it could also be due to the change in activity, related to COVID during that time. So
Yeah,
hard to
very
say.
interesting. Great talk.
Thank you.
so much. So our next speaker I'd like to call to the stage is Kaya de Barbro.
Hi, everyone. Is this? Do a thing here, too. All right. All right. Hi, everyone. My name is Kaya Barbro. I'm assistant professor in the psychology department. And I'm going to talk to you today about some lessons we've learned in studying everyday interactions in development. So the picture from a typical home situation, you can believe me because I have an 18-month-old now. It's 8 a.m., you're trying to get to work on time, your lunch hasn't been packed, the kids are still in pajamas, and you haven't even had breakfast yet, right? From the perspective of a developmental psychologist, these home situations are not just pure chaos, right? There's structure and regularity in the behaviors of the child and the parent, in the interactions of the child and the parent, as well as the stressors and the resources of each family that are dynamically influencing each other in real time and over extended longitudinal periods. The structure and the regularity of these everyday experiences are a foundation for children's learning. And what I mean by that is they form the literal inputs that children have available for learning. So what I want to convince you of today is that there's unique variance available in everyday home environments that we're missing out on if we're only studying children's development in laboratory, structured laboratory sessions. So in my lab, we use mobile and wearable sensors to characterize the complex structures of everyday experiences. So here are a set of sensors that we use to capture everyday home activities in our studies. So you can see infants wear motion and physiological sensors. Actually, their parents wear these as well. Infants wear a continuous audio recorder and a vest on their chest that we can use to capture all kinds of aspects of the rich structure using both human annotations and automatic machine learning algorithms. Families, in particular the moms, respond to phone surveys like the previous speaker was sharing about the ecological momentary assessments. And then we also can put an app on parents' phones to capture aspects of their phone use. We give families in our study this kit, this mobile sensing kit for a week, and we ask them to record up to 72 hours of data from their families in that time, over those 7 days. At the same time, they're responding to about 6 EMAs per day. To date, we've run 87 infant families through this study, as well as 20 families with toddlers in collaboration with Whole Communities Whole Health. So one of the first lessons that we've learned as we started to analyze our data is that structured lab measures do not represent the heterogeneity of infants' experiences. So this is a project in which we've assessed caregiver sensitivity across occasions throughout the day using the audio recordings. And what we observe is that everyday caregiver sensitivity is dynamically fluctuating across the day. So mothers who, on some occasions, mothers who are showing very high levels of sensitivity. If we look at other occasions, they're actually, it's quite likely and quite frequent that they also show quite low levels of sensitivity. And we've found that regularities in everyday context predict dynamic changes within participants, right, of their caregiver sensitivity levels. So my student Neha is going to give you some more details about that, but in the meantime, you can make some guesses as to what are the kinds of regularities in your everyday structure that might affect caregiving sensitivity, especially if you're a parent. So in another project, this time we're looking at changes in the amount of speech that families have over the course of a day and how much mothers are speaking with their children. And again, here we're finding that regularities in the everyday context, this time in whether or not the mom is using her phone, as in her screen is on or off, are predicting dynamic changes in her parenting quality. In this case, the volume of speech that she's speaking to her child. Okay, so in structured laboratory sessions, moms are not speaking on their phones during free play interactions. They are not across the room from their children washing dishes as they're engaging with their child. And there's no toddlers or other siblings, right, screaming and competing for their mother's attention. So these are sources of variance that we're missing out on when we only study children's development and the factors that we think matter for that in the laboratory session. Additionally, when we're in the laboratory session, right, we get a single sample of children's behavior. So we get a single 5-minute sample. We don't have the opportunity to observe the variability in the inputs or the experiences that children are having and their potential role on and importance for children's learning. Okay, another lesson, and the final lesson that I'll share with you today, is that some everyday processes take hours, not minutes, to arrive. So this study done with my student Miriam Mickelson, and we're looking at how how mom's exposure to infant crying affects her mood and mental health. And what we do for this is we look at self-reports. So every time the mom responds to that EMA saying what her mood is, we synchronize that data with the audio data, and we can look at how much crying happened in the 10 minutes, for example, prior to the mood report, and whether or not that predicts mom's mood. So what we've found is that crying exposure predicts immediate increases in mother's negative affect, and that's whether we're looking at the 10 minutes prior to the mood report, the 1 hour, the 3 hours, or the 8 hours, how much crying happens prior to that mood report. But the story for maternal depression symptoms is different. So if we look, crying does predict increases in maternal depression symptoms, but only when it is above average for 8 hours, right? So our interpretation here is that depression symptoms they have much more momentum, right? They're much harder to shift. And so mom isn't immediately, when her baby cries more than average, she's not immediately feeling bad. But if a baby is crying for more than average for an entire day, that's when we start to see shifts in maternal mood, right? So the kind of high-level story here and the high-level lesson here is that there's certain types of processes that take literally hours or days to unfold, and that we're not going to be able to capture those if we're only studying parents and children in structured laboratory sessions for 5 minutes at a time. So why study everyday experiences in development? I argue, and I hope I convinced you, right, that there's expansive time, space, and caregiver responsibilities at home that are providing unique variance that is affecting children's experiences with likely implications for how and what children learn. So I'm happy to share this paper that we just recently published with Caitlin Fauci, and just to say thank you for being here. Thanks.
We have a question in the middle of the room.
Hey, Peter. Go ahead, Peter.
Correlated with any ground truth information about the mom. Say, if the mom's personality is a certain way, it takes shorter or longer period of time,
Yeah.
for her to be irritated. Thank you.
So the question was whether, I'll just repeat for the video folks, the question is whether there's any kind of moderating factors that influence the relationship between the crying exposure and mom's mood, changes in mom's mood. And we're actually, so in the first study that we did, we haven't been able to look at moderators, but we have things like parenting self-efficacy and social support, and we're using those, we're starting to test those as moderators to observe them to see if that's the case. You can ask Meg for more details about that.
Great. we don't have a time for a second question, but definitely during the mingling session, feel free to come up to any of the speakers and ask questions. So I'd like to bring the next speaker to the stage, which is Miriam Mickelson.
Hi, I'm Miriam. I'm a second-year student in the clinical psychology program. I work with Dr. Barbro in the daily activity lab, and today I'm going to be presenting on the influence on parental phone use on their interactions with their children. Sorry. It's well established that parent-child interaction communication really creates the foundation for children's social, emotional, and cognitive development. Child-directed speech is considered a particularly important predictor of language acquisition and cognitive development. As mobile devices become more and more integrated into everyday life, there's a growing concern about how they might impact these critical early parent-child interactions. So far, studies are showing that they do decrease engagement between parents and their children. These studies are conducted in laboratory settings, often over short spans of time. So we're really not getting a lot of insight into the real-life dynamics between parents and their children in the home, and that's really where the bulk of development is happening. So our question is, do these trends carry over to the home? Do we observe real-time changes in maternal and infant speech during instances of maternal phone use? Our study consisted of 12 mother-infant dyads in the context of the larger study that Dr. Barbro just explained. Each dyad was given sensors to wear over the span of a week and collected up to 72 hours of data. To track the mother's phone use, each mom downloaded a mobile app called Bayway that tracks screen usage, so whether the screen is on or whether it's off. Each infant had a vest with a audio recording device called Lena, and Lena has a software that classifies every instance of speech or every utterance into a category, and the categories that we were interested in were female adult speech, that I'll refer to as maternal speech, and child utterances or any vocalization that the infant makes. Finally, the infant also had an accelerometer, and we used this motion data to estimate and control for infant sleep in our analysis. So to address our question of the impact of maternal phone use on how much moms and children are speaking, we looked at maternal word count for every minute when the mom's phone was on and off, and the same thing for infant vocalizations. So here what we're looking at is one participant's data. So there's a lot of variability in speech over the course of a day, so we broke up our analysis into every hour. So here on the x-axis, that's every hour interval during the day from 7 a.m. to 7 p.m. And then the y-axis is maternal word count per minute. So here in blue, we're seeing this is a maternal word count per minute, the density plot of this for one participant when the phone is on. And in yellow, we're seeing that same density plot of word counts when the phone is off. So for this one, we can see pretty clearly that she's talking a lot more. There's a lot more speech happening when her phone is off. And we found that the trend seemed to carry over to the rest of the participants. So here on the left, this is the same kind of plot we were looking at the previous slide, but now this consists of all of the participants in the study. And again, it appears that moms are talking a lot more when their phones are off. And on the right is the child utterance counts, so the infant vocalizations, and we're seeing a similar pattern of children also vocalizing less when their moms are on their phone. One of the trickier aspects of working with such high density ambulatory data is that a lot of times this data is very skewed with a lot of zero values. And that really complicates the statistical analysis. We're working on determining the best statistical strategy for assessing significance in our findings. We have run Anderson-Darling tests to assess the difference in the distributions and found that there were significant differences in word count for the mothers in 8 out of 12 hours and for children vocalizations in 6 out of 12 hours. So broadly, our findings really highlight that how the ubiquitous context of parental phone use in the home can have a real impact on caregiving behaviors and ultimately has the potential to really impact language or cognitive development. Thank you.
Do we have any questions in the audience? Oh, yes. Here.
Yeah, I was curious how these, very relevant findings, how you think that they could be effectively translated to like the community, to, I guess, encourage a change in the use of phones.
Yeah, that's a great question. I think just like awareness, because phones are just such a part of our lives. It's not even, you get a text, you're looking at your phone. And I think that for parents to have this awareness that this can actually really impact like their children's development and like long-term outcomes, I think with that knowledge, that could be very important for children's development.
Thank you so much. And our next speaker will be Neha Momin.
Good afternoon, everyone. My name is Neha Momin, and I'm an undergraduate research assistant at the Daily Activity Lab, led by Dr. Kaya DeBarbaro. I'm excited to share with you all my presentation, Maternal Sensitivity in the Wild is Highly Variable and Systematically Varies Across Contexts. Sensitivity is defined by the timeliness and appropriate manner in which a caregiver responds to infant distress. Sensitivity is critical because it forms the foundation for an infant's social and emotional development with implications for mental health and school success. But what factors can impact how an infant experiences sensitivity? Traditional measures of sensitivity are typically assessed from short, free play settings, but these assessments rarely contain instances of infant distress and restrict variability associated with everyday caregiving, where caregivers may have other responsibilities at home, including taking care of other children. While gold standard sensitivity assessed in free play may represent caregiving in ideal conditions, we don't know about the variability of caregiving in the wild and how everyday home contexts may influence caregiving. Our research examines the variability of sensitivity by analyzing 24-hour audio recordings of infants' everyday home interactions. We hypothesize that everyday experiences will systematically affect caregiver sensitivity. Our data came from infants wearing a Lina audio recording device for 72 hours over a span of a week. The sample selection consisted of 28 infants that had 24 continuous hours of recorded audio data, which went under 3 rounds of annotations by research assistants. First, instances of cries occurring within 5 minutes of one another were grouped into a single infant distress episode. Next, these episodes were annotated for sensitivity and contextual factors, such as the caregiver talking to another person or doing chores. Now let's take a look at what we found from our data. This graph shows the percent of distress episodes that were responded to by mom. We found that 17% of all responses to infant distress were from a caregiver other than mom. This is important because it indicates that responses from other caregivers should also be taken into consideration when analyzing sensitivity
instead of only looking at responses by mom. This graph plots the sensitivity of each mom's response to their infant distress. The x-axis shows how each individual participant, and the y-axis ranks how sensitive each response to an infant distress episode was. As you can see, the range of sensitivity scores within each mom varies greatly, and this variation occurs across all the moms. This variation means that a single measure of sensitivity is missing a large portion of what an infant experiences. Multi-level models indicated that rankings of everyday maternal sensitivity to distress was highly variable across individual instances of distress, with 63.5% within-person variance. Next, we looked at potential predictors of these variances. Looking within one mom, what helps predict when they are being more or less sensitive? Let's look at the relationship between emotional intensity and sensitivity. As the percentage of time in high emotional intensity increases, the sensitivity decreases within each participant. Controlling for participant mean differences in emotional intensity, within participant increase in the presence of other emotionally intense interactions during the distress episode predicted decreases in caregiver sensitivity. This indicates that emotional intensity may be a factor that works dynamically to predict mom sensitivity in the moment. Qualitative descriptions reveal that 75% of ongoing emotionally intense interactions involved an argument with or a tantrum of another child. We also looked at differences in the presence of other individuals or ongoing chores did not predict sensitivity at the within or between persons level. The first graph shows participant mean media presence was associated with decreased caregiver sensitivity. However, we found that the within-person differences in media presence were not predictors of sensitivity. Our research shows that there is a high within-person variability of caregiver sensitivity. The results suggest that typical measures of sensitivity to distress are not representative of infants' everyday distress and regulation experiences. Additionally, variation in mother sensitivity to distress is associated with both regular and dynamic structures in their everyday ecological environments. For the future direction of this study, we will compare the implications of home-based, highly variable sensitivity ratings to gold standard free play assessments of maternal sensitivity within our own sample. Thank you for your time. Does anyone have any questions?
Any questions from the audience? Wonderful. Take some time to talk at the mingle and ask questions. I'll call the next speaker to the stage, which is Anissa Saleh.
Thank you. Hi, everybody. My name is Anissa Saleh. I'm a doctoral student working with Dr. Barbro, and today I would like to talk to you about a collaborative effort I've been leading studying the acoustic features of depressive marked speech in a Spanish-speaking Latinx sample. For starters, early language development research has traditionally been focused on children's ability to rapidly learn words connected to objects and context. While object recognition is integral to language learning, it often leaves out the expressive intonation of maternal speech. Kids are exposed to speech, sentiments, and emotion in the everyday, and I propose that how words are spoken and caregiver emotional state matter for long-term language trajectories. Past research has shown that maternal depression is associated with a lower word count and emotional expressivity and has implications for infants' emerging language development and can alter language trajectories. Symptom detection in particular is relevant as subclinical symptom severity predicts various child outcomes continuously. The ability to successfully classify depressive symptom speech could lead the way for more immediate just-in-time interventions. I've been working on building 2 acoustic detection models, one in a Spanish-speaking Latinx population and another in an English-speaking mostly middle to upper SES sample. Today, I want to share some of the considerations that we've been faced with in making these models a reality for use. For starters, the everyday context matters. Depression in the home varies greatly versus a more traditional lab-based setting. We're trying to get at feelings of depression, sadness, and hopelessness in 10-minute auditory increments. Imagine detecting acoustic depression in the home. There's multiple sounds going on. A door can be opening, a dog could be barking, a TV could be playing, and we're sometimes accounting for overlapping speakers at the same time. In our past model work, we have found that models trained on real-world data don't perform well on our infant data. If we want to detect depression in an everyday context, we need to collect data from the everyday. We also need to consider language-specific acoustic features. As has been true in prior work in acoustic processing, tempo-spectral features such as MFCCs, spectral prosody, and melody are all the most reliable for classifying depressive symptoms, depressive speech. This, in turn, can present a really unique challenge when Spanish speech, which simply due to its linguistic properties is high in the prosody of everyday tone. When building a model, we need to both train and test our model on Spanish-speaking language-specific data. Lastly, I would like to discuss the timescales of measurement. Based on our knowledge about parent-child interactions, we've been hoping to use these 10-minute increments, but we have measures of depression from ecological momentary assessments, or EMAs, that are occurring immediately to within 2 hours of speech. We also have a much longer timescale with questionnaires being filled out 2 weeks prior to recordings commencing. Prior work in our lab and in the field has shown that depression doesn't change rapidly, but negative affect does. These questions of timescales are vital to model prediction. Our Spanish sample had questionnaires assessing mood at both the longer and shorter timescale, seconds, minutes, hours, days, and weeks. So which of these self-report measures should we use when we're training our acoustic model? Each one of these sources of maternal self-report has a distinct implication about the timescale at which depression is unfolding. It's unlikely that a 2-week questionnaire can model immediate changes if we think the timescale's at days. Similarly, at a 6-day measurement, it could simply be overkill and overburden participants. Timescales must be considered carefully for model prediction. Key determinants in the everyday environments of our Latinx sample have to be taken into consideration, namely the presence of background media or multiple speakers, linguistic patterns emphasizing prosody, and dynamic changes in mood following the questionnaire. Collectively, these all frame crucial aspects of children's early language environments that we're striving to examine in the model. I would like to end here. I propose that we need to build models for the everyday context that are specific to the community and that fit the timescale of our questions. Models are not a one-size-fits-all, and our research questions, communities, and participants all deserve the attention of attending to the unique context that we're attempting to study, the cultural situationness and the behavior of beliefs. Thank you. Does anybody have any questions?
Peter?
Yeah.
They're coming.
Yeah.
Thank you. So it can vary between minutes to hours to weeks. I guess my question is, say that you could build 2 models. One could predict the fluctuation on a more temporally granular manner, and the other one is predicting more a trait-like outcome. Which one does would the community care more about if you presented these 2 options to them, saying you can make a change in either one? Thank you.
Let me reframe your question and make sure that I got everything. So you're asking about the timescale of what a community might care about at a shorter timescale or a longer. So yeah, I'm framing these questions very much thinking about an early language environment. So these shifts are happening automatically and we're seeing changes in maternal birth count or how that's impacting just an everyday interaction. I think at that point we're caring about how these things are unfolding. So if I'm a mother and I'm feeling more depressed on one day and I can predict a change in acoustic feature, that may change how I'm holding my child, how I'm interacting, where I am in a room related to where they are. But then if I'm coming at it from more of a clinical standpoint, this ability of predicting depressive change that is long-standing and
has reliability for treatment. Perhaps a longer time scale that is truly getting at depression and not negative affect may be more reliable. Thank you.
So much. Our next speaker is Daniela De Luca.
Good, right? I'm not tall, but thank you. All right, hi, yes, my name is Daniela De Luca, and I'm an advertising PhD student. And today I'm going to be talking to you about the role of self-construal theory in the context of HPV vaccine message acceptance. So, as you may know, HPV is among the most common sexually transmitted infections, but there's a vaccine that helps prevent the infection and HPV-related cancers. Tiempo de Vacunarte is a project set in El Paso, Texas that promotes free vaccination among Hispanics. But in their preliminary qualitative analyses, they found that there are social-cultural factors that influence Hispanics' decisions not to get the vaccine. This is consistent with previous research, and some examples include the idea that males don't need the vaccine, or perceptions that getting the vaccine for your kid is like endorsing premarital sex. We wanted to use social cultural factors to instead promote the vaccine and persuade them to actually get it, and thought that it would be a good idea to appeal to their extended family's well-being, just because Hispanics are quite known for being close to their small communities. And so that made us think of self-construal theory. For those of you who are not familiar, self-construal posits that how you define the self greatly depends on your relationship with others. And so in a continuum ranging from independent towards interdependent, we should all fall somewhere in between. And so in seminal articles, they used to compare American culture as highly independent with East Asian cultures as highly interdependent, just because they're more likely to think about the impact of their actions on their whole community, while Americans tend to value independence and individuality. Previous research suggests that Hispanics should fall somewhere in between. In the context of health, self-construal has been used differently depending on the health behavior. So when it comes to behaviors like protecting others, like wearing a mask during COVID times, then it makes sense, right? Protect your abuela or your grandma, wear a mask, save her from COVID, right? But in context that it's more about protecting yourself and indirectly protecting others, like a vaccine or wearing a condom, in those cases, self-construal has been used almost interchangeably with perceived norms. And I find that odd because to me, they're not exactly the same thing, even though I notice that there is a relationship. And so to explain the difference, I would like to use an example. If you think of a male Hispanic who's a weightlifter, and he sees that his peers are using steroids and that his coach approves of that behavior, if he were to use steroids, then that would mean that perceived norms are influencing his behavior. But self-construal is different. If at the time of making that decision, for some reason he thought about his abuelita, then that means that he has a high interdependent self-construal because his identity with, or his relationship with his abuelita is such a part of his identity that he thought about her even though she really doesn't have much to do with his weightlifting activities. And so previous research suggests that you can trigger someone's self-construals with messages, and I wanted to work on that differentiation in the HPV vaccine context just because I feel like it's a middle ground between the two. And so my hypothesis was that if I created a message about the HPV vaccine and appealed to family well-being, that Hispanic populations would be more persuaded. I was given the opportunity to include some items in a Texas-wide survey, and basically I exposed over 1,000 Texans to one of three messages. One appealing to their individual well-being, the other one to their family, and the last one to Texas as a community. Unfortunately, there was not enough evidence to support my hypothesis, but of the three messages, the one that appeared to be most influential was the Texas one, and that was among both Hispanics and white populations. And so, I mean, I wasn't expecting that, but I think it makes sense because Texas is quite known for being proud of Texas, so I think that they just like the message. I think there's something to work on here as well. But going back to self-construal, this was just a pretest, and I want to run these analyses again, make like a full-on study. And so the next steps are basically to run my manipulation checks again. I want to create more stimuli, adjust my messages, include imagery. I also want to try it within subjects analyses because I feel like even though you may have a high interdependent self-construal, that doesn't mean that a message saying protect yourself is not going to be persuasive, right? What I need to test is if the same individual would be more or less persuaded by one of the other two messages. And finally, because of the nature of the survey,
I was asked to cut down on my scales, and so this time I'm going to use my complete scales for all my variables and even add in some items. I was thinking that maybe political affiliation might play a role here, how highly you identify with Texas, whether you're first, second, or third generation Hispanic in the United States. And finally, I would like to control for variables like perceived risk or severity, obviously of HPV. But any suggestions, any advice would be highly appreciated. Thank you.
Any questions for the speaker?
Hi. I was just wondering if you've thought about messaging for like friend-to-friend references, like I got the vaccine, here's how you can get it too.
Yes,
And has that
actually-
been a part of how you've tried
Yes,
to...
that's one of the messages that we were working on. As I said, I was given like this opportunity and I was like, yeah, here's one message. But yes, in this study, I want to try working on several messages, and one of them is appealing to like that sense of, amigo, come over, I did it and you can do it too. Yeah.
Very cool. Thank you.
Thank you so much.
Thank you.
Our next speaker is Dominique Nicole Egger.
Hi, everyone. I'm excited to be here. So I think we can all agree that COVID has had a mental health toll for parents and children alike. After the onset of, thank you, I appreciate it. After the onset of COVID-19, mental health-related hospital visits increased for children, and prevalence rates of depression and anxiety in adults were higher after the pandemic onset than rates of all adult mental health disorders combined before. So mental health has worsened for kids and parents during COVID, but we still need to do more work to understand how exactly mental health has changed since pre-COVID rates and what current mental health looks like for children and families. The current study looked at mental health trajectories for Latinx parents and their preschool-aged children during COVID-19 using a longitudinal analysis. Okay. Oh, wait. Oh, I'm sorry. I thought it was showing the first one. This is my beautiful opening slide. Here's my second slide. So to conceptualize how COVID-19 may affect families, we used a model suggested by Prime et al. 2020, which was based on pre-existing systemic models of human development and family functioning. It proposed that COVID-19 caused social disruptions such as job loss and confinement, which in turn affected both children and family well-being, or children and parent well-being, and that these effects were moderated by familial processes such as belief systems and values. And additional pre-existing familial vulnerabilities such as poverty, racism, and marginalization, and other experiences with trauma can impact how families responded to the social disruptions. And so we know that the pandemic has kind of affected some groups more substantially than others. And so a systemic review of 19 studies across 8 countries found that women were at the greatest risk for mental health status during COVID-19, above and beyond other environmental factors. Black and Latinx individuals were also more likely to report negative mental health outcomes, more than white individuals. And these findings are not universal. These disparities are not new, and some research has suggested that the discrimination of racial and ethnic minorities may have actually increased since the onset of COVID-19. And we also know that these identities don't exist in a vacuum or exist by themselves, and the mental health impact for women of color might be more substantial. So most existing research on family functioning during COVID shows the above trends. Samples are homogeneous and in the US largely white, and this is despite the evidence that I just talked about, where populations that have been marginalized may be disproportionately impacted. Analyses are largely cross-sectional, which makes it impossible to compare to pre-COVID rates. And then those that do report on pre-COVID rates are often using retrospective reporting, which is subject to bias. So in the current study, we sought to address these concerns. So our sample was collected from 12 preschool or public schools in Corpus Christi over the course of 2019 and 2020, so before the onset of COVID-19 and after. The target child was in pre-K, and while our sample was fairly homogeneous, our sample was predominantly women, 83.3%, and predominantly Latinx, 88.5%. And these are two groups mentioned before that may be disproportionately affected by the pandemic. Additionally, the majority of our sample, just over 60%, was affected by poverty, and poverty has been shown to increase risk for negative mental health trajectories outside of COVID-19. The data was collected across 3 time points, starting in 2019, and using growth curve modeling, we tested the change in parental depression symptoms, well-being or global mental health symptoms, parenting stress symptoms, and child well-being, or also defined as global child mental health symptoms. So looking at these outcomes, only parent global mental health symptoms worsened across time. And so global mental health was slightly better than the national average before the pandemic and decreased steadily across time points, though this decline was only significant at time point 3. And then we have parenting stress symptoms and parenting depression symptoms, which did not change across time significantly. And finally, we have child global mental health, which you can also see remained relatively stable across time points. And so to kind of contextualize this, overall, we're seeing that families in the current study showed surprising resilience in the face of COVID-19, and this could be due to a number of factors. Some evidence exists that parenting younger children is protective against negative mental health trajectories, and the average age of the children in our study was between 4 and 5. And some evidence exists and while parent well-being did worsen, our other factors of parental adjustment did not, so depression and stress symptoms. And these factors have been linked to child adjustment previously and may help to explain why child mental health remained unaffected. And so to just wrap up, while the change was small, parent mental health did ultimately worsen, and this happened at time point 3, so not during the beginning of the pandemic. One potential reason for this is that the larger systemic supports were given in the initial months of the pandemic and subsequently removed, despite evidence suggesting that families were still suffering. But potentially more importantly, the cumulative impact of stressors over the course of the pandemic and evidence of delayed impact of high stress and traumatic life events may explain this delay. So more studies are needed that look at family functioning in families with young children representing minoritized populations and containing data points pre-COVID for comparison. This is just in order for us to understand how COVID-19 is uniquely affecting families and parents and children. Thank you very much.
Thank you. Do we have any questions? Shireen in the back.
Hi, I was wondering if you happen to know any proportion, like what proportion of the sample may have been undocumented or documented, and how much of an impact they may have had on their mental health?
Yeah, that's a really great question. So we did not collect that information for kind of legality reasons. We didn't want families to feel like they were being targeted or like we were a system that was trying to collect that information for any particular reason. So we don't know that information. I will say that in Corpus Christi specifically, while it is closer to the border than other cities, like Austin, for example, there's a high percentage of second, third, and fourth generation families or more. So the majority of our sample did report being kind of second, third, fourth generation. That does not necessarily kind of speak to documentation, but might be related.
Great. Thank you so much.
Yeah, thank you.
Our next speaker this afternoon is Hagen Fritz.
Hello, everyone. My name is Hagen Fritz. I'm a PhD student within the Civil Engineering department. I'm kind of the primary creator of the Bevo Beacon. So if you hear good results about the Bevo Beacon, that's from me. And today I'm going to be talking about how I was able to use data fusion across both a mobile, a wearable, and a stationary being the Bevo Beacon device, in order to predict bedroom occupancy, and to be able to kind of augment a pre-existing data set that I had used in my analysis on sleep quality and indoor air quality. So these data come from the UTX-1000 study, and so that indoor environmental monitor, that's the Bevo Beacon. We measure a variety of indoor air pollutants. The ones that are relevant for this analysis are carbon dioxide, which we emit when we exhale, as well as volatile organic compounds, which we also emit when we breathe. And then we also have, as many people have mentioned, that smartphone app. We get GPS data from that smartphone app so we can tell where participants are located. And then lastly, we have that wearable, and that wearable, for my purposes, tells us when we have sleep episodes, and so we can actually use those sleep episodes to kind of determine when the bedroom is occupied, because you can, relatively good assumption is that when you're asleep, you're in your bedroom. This, like I said, was from that UTX-1000 study. We had about 20 participants that at least had data across all 3 of these modalities, and this was for about 11 weeks during the summer of 2020. So I want to kind of go through the pre-processing step, because I think it was kind of a neat way of looking at all data from all of these 3 modalities, but I will have to apologize. There was a few formatting issues, so if things look a little goofy, I apologize for that. So if we have continuous indoor air quality data, in this case, again, we're just kind of looking at CO2 and VOCs, volatile organic compounds. We also have GPS data that's coming from that smartphone app, and it's a little bit irregular, kind of depends on if the participant's smartphone is on or connected to the network, and even if they're moving, right? If they're not moving, we're not necessarily going to collect any of that data. We first can determine when those participants are home by cross-referencing the GPS data from the smartphone app with the addresses that they provided when they were enlisted into the cohort study. And then we can look at the sleep episode. So we take the data from the wearable, and we can actually find when they're actually asleep. And so now we have an idea of when they're occupying the bedroom. And that is important because the environmental monitor is in their bedroom. And so we're really only looking for predicting occupancy within that bedroom. And then we also have GPS data outside of when they're home. And so we can label that data as unoccupied. And so I trained various amounts of machine learning models, both on a various amounts of machine learning models, splitting my data into a train and testing set, and was able to get, for 13 of those 20 participants, models that were about 80% accurate when it came to predicting the occupancy, just based on VOCs and CO2, using kind of a simplified neural network model. And so that's all fun and well. It was a neat analysis, but in order to use that for something kind of instructive and purposeful, I wanted to apply it to data that was unlabeled, so data that we didn't have any GPS data for, or perhaps perhaps the participant forgot to wear their wearable to sleep, and so we don't necessarily know if they're occupying their bedroom or not. Oh my. Okay, there we go. And so for a few participants, if you look at that right-hand column, we're able to get only a few data points back with about 90% confidence that they're actually in their bedroom, that the indoor air quality data is from when they're actually occupying their bedroom. But for some participants, like those last 2 that I'm showing, we're able to get 4,000 data points back, which is nearly 30–40% of the data that we had to just throw away because we weren't able to label it as being from occupied or unoccupied periods. And for those participants in particular, it's really nice because a lot of the analysis I do kind of depends on knowing that the participant is in their bedroom. So we can do things like use the CO2 concentrations to calculate ventilation rates, or if I'm looking at indoor air quality and sleep quality, right, I want to make sure that my participants are actually in the bedroom, right, and we're actually looking at data that we're gathering both when the participant is in the bedroom and when we're actually getting air quality data from those periods. And so this was just a way to augment that data set, when we did have kind of some missing data there. And again, for some of these participants, we're able to get a lot of that data back, which is very nice. And that is all I have for you, so thank you for your attention. I'm able to answer any of the questions that y'all may have. And thank you for many of y'all in the audience who have helped me along this way.
Thank you. Do we have any questions? I'm closer.
Yeah, I was wondering if, did you have any plans to add some kind of feature to the Bevo such that it could connect to either, the Fitbit that the participant's wearing or their phone like as a double check that they're actually, in the room, or maybe a more direct way of checking for that?
Yeah, unfortunately, so the main microcomputer that's within the Bevo beacon that controls all the sensors and it's the brains of the whole thing, it does have a way of pinging and finding Bluetooth MAC addresses, but we didn't have that feature on for whatever reason. And so we don't have any access to that data, but it very well could be turned on, and you can ping just kind of the MAC addresses that are from Bluetooth devices that are in the area. Now, I don't necessarily know if we can get the MAC addresses from the participants, but you'll be seeing the same MAC address over and over and over and over again, and I'm sure Peter could whip up a nice little algorithm that kind of determines who that participant is, if that's the participant in that bedroom. So again, it's not 100% accurate, but it is a way to kind of tie in a little, even more data, right, which is great to kind of predict that occupancy.
Great, thank you so much.
Thank you.
Our next speakers are Shireen Garcia and Ashley Trimpe. And because we are recording, it's best to be as close as you can to the microphone. So I'm going to lower it. And you guys can feel free to up and down, whatever makes you most close.
Hello, welcome to our presentation. Let me do this. There we go. Welcome to our presentation on the Community Strategy Team for Whole Communities Whole Health. My name is Shireen Garcia, and I'm the Community Engagement Specialist for Whole Communities Whole Health, and I also co-facilitate the Community Strategy Team, or as we're probably going to call it, the CST, along with Dr. Esther Calzada. And I'm here today with one of our CST members, actually.
Hi, my name is Ashley Trimpe. I am a substitute teacher and a parent in the Del Valley School District. I joined the CST team in September, and I was nominated by a school coworker who knew I had a long history in the area for advocacy for my community and my students at the school. So what just is a community strategy team? They're a group of community members who provide input on issues related to health, well-being for children and families in Central Texas. Specifically, the area is Del Valley with some of their surrounding Travis County, ETJ, whatnot. We have monthly meetings, and we're involved in many whole community, whole health groups, work groups, and other things. As you can see, our community strategy team is made up from an abundant amount of community people, some in the healthcare field, some in the educational field, and then some like me that are just parents who enjoy advocating for those that need it. Shireen?
So why do we even have a CST in the first place, right? We at Whole Communities Whole Health, we really believe that research should be mutually beneficial to both the researchers and the participants who are in the research project, so people who are members of that community. So how do we conduct research in a way that's beneficial to the community that's participating? Well, we have to find ways of collecting data that's useful to them, so data that they can use to learn about themselves or to leverage that information for creating positive change, whether that's through policy or other kinds of change, right? So to create a place where the community can thrive. And so how do we know what data is useful? Well, it's really simple. We just ask them, right? We involve them in the research. We welcome them in. We invite them to join the CST community strategy team or to go to a focus group or be involved in another way through other events that we also have. But the CST really is our primary way of doing that. And so the CST is involved in giving feedback and advice on our research methods, research questions. They help raise awareness of whole communities, whole health in the community by helping with recruitment and things like that. Once the study gets underway and we have actual data to work with, they will be involved in interpreting the data and also in developing plans for how to present that back to the community. And in the last couple of years, they've really taken initiative to create a community response plan, which is basically a set of guidelines and recommendations on how they would like to see whole communities, whole health, respond to different health issues, whether it's something at an individual or familial level that may be adversely affecting the family. So we might do a basic needs assessment there. Well, we do that with all of the families. That was the recommendation. All the way up to when we start to see trends in something that is occurring at a broader scale, right? So a more communal issue. And then we may, that they are recommending that we would take a role in helping to mitigate that, right? And so part of the recommendations in that plan was to do some health info sessions. So they actually are taking initiative this year to put those on. They're organizing one session a month from January to June right now. In January we had a session on bullying in schools, which Ashley helped organize. And just last night we had a youth town hall on COVID-19 vaccines, which was awesome. We had a great turnout. And we had a couple of youth panelists in addition to some other panelists from the CST and other community organizations. So there have been really amazing events. We're really proud of our CST. We're really thankful to them. Thank you, Ashley, for being a part of it. And thank you to all the CST members for their contributions. We really wouldn't be the same kind of project without them. And so with that, I'll just close it out and take any questions if there are any. Thank you.
Any questions from the audience? Clint's coming with the microphone. Hi, thank you. A lot of people have the bias that, or the belief that involving participants in the research process creates a sort of skew to the data. How do you address those concerns when you're sharing this with the community, and especially with funding agents and the like?
Can you say the last part again?
Like with funding agents and with the broader academic community.
Right. I guess so at Whole Communities Whole Health, we're fortunate that we are largely funded through the Office of the Vice President for Research. And so that allows us a little more flexibility with that kind of thing. I think that when we look at, is it skewing the data, we have to also factor in what is our responsibility to the community. And so that we're not only doing research that we think is scientifically pure. That is one way of doing it. But when we're working with communities that haven't historically been involved in research, we really have to factor in their thoughts and opinions to do it in a way that is culturally sensitive and appropriate.
Thank you so much. Our next speaker today is David Jarmer.
Hello, I'm David Jarma. I work with Carrie Kinney in civil engineering, and today I'm going to be talking about the viability of community-provided dust samples as a tool for indoor environment studies. So in the U.S., we spend nearly 90% of our time indoors, where we're often exposed to higher concentrations of pollutants such as fungi, chemicals, and allergens compared to outdoor conditions. So how can we study these exposures? Well, home air conditioning filters act as particle samplers that collect particles over the entire time that they are installed in the home. Therefore, the dust that collects on these filters can be analyzed to determine and explore some of these exposures. So conventionally, researchers are going into homes and collecting these dust samples themselves, but obviously that is time-consuming and it can be invasive to the homeowners. So in this study, we're investigating using community-collected samples to expand the reach of the study, as well as continue collecting this data during a pandemic when we can't really get into those homes as easily. So the main questions we're going to be talking about are, can we collect samples and metadata remotely, and can sample integrity be maintained as these samples are being shipped back to the university? So how are we doing this? For the community-based approach, vacuums and sampling kits are sent to the participants, who then sample half of their existing filter shown in red, and then send that sample back to the university. About a day later, researchers are going to these homes and sampling the remaining half of this existing filter. Additionally, in this visit, a new HVAC filter is installed, and then 60 days later, the researchers are going back and taking a third final sample. My text is a little messed up. But additionally, participants are completing surveys about home factors that we hope to investigate in the future. So how well is this working? Well, so far we've done 2 rounds of sampling. In 2019, before the pandemic, we collected samples as described in the previous slide, but in 2021, we collected samples remotely only via the sampling kits that we're sending out. So in 2019, we were fairly successful in maintaining participant engagement, as 93% of our participants completed the entire project. But in 2021, when we moved completely remote due to the pandemic, we did have some struggles maintaining that participant engagement. Oh no. Okay. So another important component of remote sample collection is the shipment of these samples from the participant to the researcher. Shipping protocol was designed to keep samples below 50 degrees for 24 hours to ensure that the dust remained representative of the home environments that they were sampled from. In phase 1, 93% of our participants returned their samples, but only 72% of the samples were returned following this shipping protocol. So shipments with insufficient ice, or that were shipped over the weekend instead of overnight, would lead to increased temperatures and or shipping time, and can potentially misrepresent the home environment that we're trying to study. So overall, how do participant-collected samples compare to researcher-collected samples for one of our pollutants of interest, which is the fungal community? Oh boy. So on this graph, points that are closer to each other are more similar, and points further apart are more different. So looking at the participant-gathered and researcher-gathered samples from the same filter in green and orange, you can see a lot of overlap, which indicates that these 2 sample types are very similar. And then when we compare these to the samples collected 2 months later, we can see that there is a greater degree of difference. Okay, so in conclusion, community participants mostly were actively engaged. Most of them completed the project completely, but we do suggest that if you are going fully remote, that you do use some kind of Zoom or video call to further engage with participants, creating that face-to-face connection. But protocol-wise, most of our participants followed the collection and shipping protocols. Currently, with this work, we are still investigating the shipping effects on other pollutants besides fungi, such as bacteria, plasticizers, flame retardants, and allergens. As a part of a bigger study, we're using remote collection of samples and survey data to explore the links between the home environment, the pollutants present in homes, as well as respiratory health eventually. And later this year, we plan on expanding this remote data collection across Texas. So finally, I'd like to thank the U.S. Department of Housing and Urban Development, as well as Whole Communities, Whole Health, for supporting this work. Thank you.
I'm just curious, how did you track the amount of time for the sample to stay under different temperatures? How did you know that?
So we had a little temperature sensor. It's called a hobo, actually. But we put them in the packages that they ship with, and that gives us, in 2-minute increments, it gives us the temperature, the relative humidity inside that package.
Thank you so much.
Thank you.
Our next speaker is Isabella Mcconnelly. Let's get the podium set up exactly for you. Okay. Let's move it a little higher.
Great.
There you go.
Okay, thank you. Hi, everybody. My name is Isabella, and I'm going to be talking about our study that we did. Ooh, this microphone's very loud. Talking about a study that we did using Fitbits to measure sleep and activity. So generally, you know, if you are more active throughout the day or you have better sleep, you tend to report feeling less stressed and feeling happier. I know I feel much happier after I've had a good 8 hours of sleep compared to when I've had maybe 6. So these things are kind of well known to be correlated to someone's individual well-being, but traditional laboratory models of sleep and activity monitoring can place some burden on the participant, and they don't have as much reflection of real-world activity and sleep patterns because, for example, an EEG is not going to, you know, directly simulate how one might sleep at home because you're in a different environment, you're in a lab, it might be a little nerve-wracking. So that, and then even with activity monitors that are medical grade, like an ActWatch, for example, would still require the participant to come back to the lab every now and then to get that device charged. So there's always this little bit of a burden on the participant in participating in traditional sleep and activity studies. On the other hand, Fitbits are widespread. People tend to know what they are. They're commercially available and they tend to be more affordable, both for a participant and for a laboratory. And they're less invasive. The charger is very simple. You know, people know how to use a Fitbit charger, things like that. And existing research on the validity of using Fitbits for sleep assessment is fairly limited. And as far as we understand, there's not much, if any, data exploring how the arm that you're wearing the watch on is affecting the data that's being recorded. So the study that we did here formally tested the effect of arm assignment on the recorded sleep activity data, as well as collected both subjective and objective activity and sleep reporting. Part of the study also allowed us to help pilot HornSense for whole communities, whole health. We were able to test out the early stages of the platform and give feedback on how to make it more suitable and more easy to use for researchers, like just the ability to edit your participants' information, like a start and stop date, making it easier to collect data. So we were able to kind of like alpha and beta test this platform. And we did collect about half of our participants' Fitbit data through this, and the other half was through Bayway. So we were also able to help develop a protocol for registering Fitbits with this database to kind of make that process a little simpler. So as far as our study that we did, we ran this from about July to December of last year, and we had about a total of 62 healthy adults enrolled in our study, and they could participate for either 2 weeks or 4 weeks. Most of them did actually go on to do 4 weeks, which is really surprising and nice thing to see. So as part of our study, they would wear both a Fitbit and the ActWatch that I mentioned earlier. So that is why they kind of had to come back after 2 weeks to get that watch charged. But they would wear both watches at the same time, and depending on which week it was, they wear those watches in different configurations, and that was how we tried to test arm assignment, make sure they didn't have too much of a role. So if they did the 3 and 4 week period, so in their 4-week cohort, then they would wear both watches on one arm and then switch to the other. And they just did 2 weeks in the beginning of the study, and then they would wear one watch in each arm. In addition to this, we also have participants filling out daily sleep surveys every single day about their sleep the night before, their mood and activity, as well as the places that they went and the people that they saw. So we collected a lot of subjective data throughout this study as well, in addition to the objective data that we collected from the watches. So kind of a lot to go through here. So basically, from analyzing the sleep diary specifically, we can even see kind of what I was saying earlier, that we're seeing similar relationships between sleep quality and happiness, as well as activity and happiness. We have similar measures for stress and things like that. So participants who reported having a higher subjective sleep quality on a scale from 1 to 5 did also tend to report having a higher general happiness on a scale from 1 to 100. And a similar trend was seen with activity versus happiness. People reporting higher activity, also a scale from 1 to 5, also tend to report higher happiness. So this is just kind of confirming what we are starting to understand about the relationship that physical activity and taking care of your sleep, which not all of us do, can do for your overall well-being and your happiness. So as far as where we can go from here, we have not had a chance to analyze all the Fitbit data or even really get close to doing that because there is quite a lot of it. It's 62 participants worth of Fitbit data, so there's a lot to sift through. But from what we're seeing so far, we do not see an effect of arm assignment on the data that's been recorded as of yet, which is a good sign. We don't want whether you're wearing the watch on the left or right arm to drastically change what's being recorded, so that's good. But like I said, we still need to do a lot of analysis. So future work for this project could examine the agreement between objective sleep measures instead of just the subjective ones we've been able to analyze so far, and the rest activity patterns that we're obtaining from the Fitbit and the ActiveWatch devices. So that's all that I have for you, so thank you.
Thank you. Any questions from the audience?
Did you take into account naps or any kind of non-overnight sleep?
We did, yes. We had a place in our surveys for participants to say, hey, I slept from this time to this time. Not necessarily saying that all of them were good about doing that, but there was a place for them to put that information in if they did. So that way, if we saw that in data that we were pulling from the watch, we could be like, oh, they were taking a nap at that point. So we did have a place for them to mention that, hey, I did sleep during the day for, X day.
Thanks.
Thank you so much. Our next speaker is Sean Upshaw.
The challenges of being tall. Good afternoon. Well, good afternoon, everyone. I'm grateful for the chance to be here today to present this awesome research and going forth. And I represent from the School of Advertising and Public Relations in the Moody College of Communication. And this is the title of our study, but I also must acknowledge my co-researcher as well, Ms. Ashley McDonald, who is also a doctoral student in the communication studies, who has assisted me in analyzing and interpreting the data. So metropolitan cities often endure disproportionate rates of health, environmental, and racial discrepancies, and especially among BIPOC citizens. And as Austin continues to grow, there will be more challenges relating to this area, which really gather both of our attention concerning the question we constructed to perhaps break down some of the experiences that many BIPOC participants within the city have allowed us to see from their perspective. And coming from that way, we actually constructed a question rather that really helps us to unpack all these experiences that relates to how and to what extent does each message identity layer describe the health, racial, and metropolitan environmental experiences among BIPOC communities. The study consisted of 32 participants that are mostly 18 years or older, and they have five, well, at least at the time, there were 5 coordinated focus group sessions that mostly focus on family processing, physical and mental health, environmental health, biological sampling, and families of color. And a thematic analysis was used to describe the most poignant things that occurred with assistance of open and axle coding. Before we go any further, I definitely want to acknowledge the theoretical framework here. In communication, we're definitely known of using, particularly my interest of using communication theory of identity. And this concept draws from the notion that identity is based on social categorizations and shared membership. And from this perspective, it helps build, sustain, and evolve one's identity. CTI consists of 4 layers such as personal, inactive, relational, and communal. Some of the noted key findings, and there are plenty of them, so this is just a snippet of what I'm able to show you within our time frame. For the personal layer, many of the participants really describe the physical and mental health challenges of dealing with their environment, their interactions with healthcare systems, and as well as looking into the influence of environmental implications regarding their health. And just for one example, environmental factors of physical and mental health and COVID-19 neighborhood support really emerged as strong factors of influence in describing how they will interpret living in Austin during the height of the pandemic. When it comes to the relational and communal layers, healthcare access really ranged a big influence amongst the participants, particularly because many of them expressed challenges of gaining or speaking access to individuals who basically are able to receive their needs and resources, and also awareness of where to find adequate healthcare resources, particularly within the community of Del Valle, which me being 2 years of an Austin resident here, it gave me a chance to see exactly from their lens what and how that experience really shaped their interaction with adequate resources, and there's a lot more to say behind that. And just to kind of wrap things up, the results for now really present us with a coherent yet robust examples of interpretation of metropolitan experiences for BIPOC communities that centers on health, racial, and environmental disparities. And additional research should investigate how gentrification, redlining, health inequality, and health inaccessibility aid the dual experiences of BIPOC communities. Thank you.
Thank you, Sean. Do we have any questions?
So how do you unpack the various different factors, historical factors that lead to environmental factors, healthcare factors that is also a result of historical inequalities, and present day things from each other when they're all kind of pointing in the same direction? So what's the approach to unpacking which factors are more important in which case?
Thank you for your question. Unpacking it really involves listening to and revisiting the stories or narratives that are used to depict certain instances various communities encounter. For instance, that for most Latinx families or Hispanic families, many of them relied on either internal knowledge or internet knowledge, mainly social media, to sort of influence or provide adequate descriptions of where to find resources, where to find support, and also noted challenges of interacting with healthcare officials, for instance, dealing with racial bias, for instance, and also dealing with the question of undocumented, and some of them didn't necessarily want to proceed in securing such resources because of that question will come up, and also language barriers as well. So primarily the narratives, the deep descriptions, and the interpretations that many of them described helped me to filter those experiences and be able to put them into layers.
Great, thank you so much. And I would like to invite Peter Wu to the stage. We'll get you set up just perfectly. Oh, more, okay, sorry.
Hello. All right, that's good. Thank you so much.
You're welcome.
Oh yeah, this is me. I'm a postdoctoral fellow with the psychology department and also the Whole Community's Whole Health Grand Challenge Initiative. Today I want to talk about some of my work using mixed type clustering to characterize daily psychobehavioral experiences of college students. The background of this work is that we in UT 1000 dataset and UT 2000, as Jennifer introduced, we collected large amounts of self-report data, often momentary, from our student participants. And these data often evaluate multiple aspects of the student's daily life. And that includes real-time mood, energy level, location type, what kind of places they are at, social context, whether they're with certain people and what kind of people they are they close friends or strangers or coworkers, and whether they're interacting with people and how, and activity of daily living, or ADL. This is a snippet of the UT 1000 data I'm showing. As you can see, the first few, this pointer is not working. Oh, it's too small. So the first few columns, as you can see, sad, stress, content, lonely, and energy, they are mood items, and they're evaluated on an ordinal scale from 0 to 3. And the next few columns are location type, social context, and ADL, and they are often multiple choice question. And then the data type is often free text like that. So a natural question that comes to me is that how do these different aspects of psychology and behavior co-occur? Or in other words, are particular moods associated with particular places, particular activities, and particular social contexts all simultaneously? So a generally good approach to answer this question is clustering, or unsupervised learning method. They can detect the co-occurrences of values in different variables. But since the data is visibly mixed type, there's ordinal, there's categorical, this kind of mixed type data poses challenges, makes it difficult for normal unsupervised learning method to work directly, such as if we use k-means, it requires a definition of distance, and it's difficult to define distance between two categorical levels. And if you use a Gaussian mixture model, that requires the data to be continuous, and that is obviously not continuous. So I found this model called ClassMD. MD stands for mixed data, from this paper back in 2015 to attack this very problem of mixed type clustering. And this method is adapted from a Gaussian mixture model. So this is some data manipulation that we did. So the first step, we used the UT1000 data, the EMA data in that data set from more than 1,000 participants. And then we converted the EMA data, those columns you just saw, into some manageable variables to feed into the ClassMD method. So what we did here is that we kept the 5 ordinal variables for mood states as is, from sadness to energy, as you can see. And then we converted the location type variables and social context variables into these 8 plus 5, 13 binary variables, representing whether they are at all those types of places, and whether they are alone, whether they are with close companion, with non-close companion, interacting in any way, and interacting in person or not. And then the second step, we used the ClassMD method on this data set across all observations in the UT1000 EMA data set. And then we set the number of clusters to 2, 3, and 4. And then we allowed unequal cluster volumes and diagonal covariance matrices to allow some freedom in the model and also make it manageable. And this is what we found. The 2 cluster results achieved the lowest, which is the best BIC value, and then we're going to present this result. The figure here shows the cluster means between the 2 clusters over all these different variables. And as you can see, there's clearly a healthy or well cluster and an unhealthy cluster. And in the healthy cluster, the yellow-orange one, the score is really high on content, on energy, and also more likely to be at a food place, shop place, gym, worship, and social place, and also to be interacting with some people or being in close contact with certain people. And that's the healthy one. The unhealthy one is the opposite of that. It's associated with being at home, and a little less so at school, even a little more less so than at a job place, and also being more sad, more stressed, and more lonely, and being alone. So this is just a result from the clustering, and I wanted to validate that the cluster membership actually makes sense. So I modeled the GPA on a scale of 1 to 100, which is also available from the UT1000 data set, using a wellness score as in the 1 variable linear model here. And then the wellness score is defined by the proportion of the healthy state. And then what we found that is the relationship between the wellness score and GPA is very significant, and it counted for more than 1.4% of the variance. It means that it's significant, but there's still a lot of factors that go into the equation. But the range of the influence here is the coefficient, as you can see, is 3.7. So for someone who's completely unwell, which will have a wellness score of 0 to 1, the range of influence on their GPA is about 4 points. So the conclusion here is using the mixed type clustering method, we found a significant unhealthy psychological behavioral state among college students, and that unhealthy state involves poor mood, spending time at home, to a lesser degree at school, and working a job, and in social isolation. And the higher proportion of this unhealthy state in an individual are significantly associated with poor GPAs. And that's my talk. Thank you.
Thank you, Peter. Do we have any questions? Kaya.
I guess I wonder if you think there's nonlinear relationships between the states and GPA or other kind of indices of the student's performance or well-being. Just because some of the factors that you mentioned, I mean, it seems like if you don't study or spend any time at school, you're not going to do well.
Yes. There certainly can be. And then actually in the literature, there's this, in the SMART GPA work done at Dartmouth back in 2014, I think, they discovered that if you spend especially if you spend time not at school in the evening, meaning that you're going somewhere or going out or something, that absence from school actually is also associated with poor academic performance. So definitely I do think there can be nonlinear relationship. Just this model still demonstrates that there is a relationship between the unwellness proportion of their daily life. Thank you.
Thank you so much. So we will now take a very quick pause to set up for the keynote speaker, but because of time, we're going to go directly into the next talk. So if we're going to pause for a few seconds and set up.
Good afternoon, everybody. I'm Sarah Kate Behrman. I'm Associate Professor in the Department of Educational Psychology and the current co-chair of Whole Communities Whole Health. Thanks to everyone for attending on this cold day. I know you all had to find your winter coats wherever they were. And thank you to all of our speakers for their flexibility in working around travel delays and all the other crazy things that have happened so far today. So for the last several years, Whole Communities Whole Health has focused on approaches to increasing representation in the study of child development. And by representation, we mean a more accurate reflection of who we are and also how we live our lives. So this means intentionally creating or considering engagement with and recruitment of participant populations that have been historically excluded or minimally included in research. It also means more accurate representation of the research questions and information that are meaningful to our community participants. Accurate representation means trying to better reflect how the lives of children and families actually unfold in terms of what we measure and also how we measure the many aspects of their lives that play out dynamically rather than in snapshots. And so you saw, I think, a really nice reflection of all the work we've been doing to those ends in the lightning round. So today's speaker, Kate Humphri, exemplifies that approach with her innovative research on how early childhood experiences, and particularly child-caregiver relationships, affect development. Dr. Humphri is an assistant professor in psychology and human development at Vanderbilt University, where she directs the Stress and Early Adversity Laboratory. In 2021, she was awarded the Infant and Early Childhood Mental Health Emerging Leadership Award in research by 0 to 3. This is only a smidgen of her many accomplishments. And actually just this week, her meta-analysis of the child maltreatment and depression literature was selected as Article of the Year by the journal Child Abuse and Neglect. Her research takes an interdisciplinary approach that brings together developmental psychopathology and neuroscience and directly confronts the methodological challenges related to culture, context, and timescale that have hampered our ability to deeply understand caregiver and child relationships. So it's my distinct pleasure to welcome her today for her talk titled Fostering Children's Resilience Through Caregiving Relationships.
Hi, everyone. And I know you got a short break, so if you need to get up at any time to use the restroom or get a drink, stretch your legs, you're welcome to. I want to thank you all for the invitation to speak here in this Whole Communities Whole Health program. It was amazing to see so many talks from various disciplines, and I'm really honored to learn from you all as well. So I hope you will find me afterwards and talk to me. I want to thank the organizers for including me, and especially for the flexibility for the other speakers. My flight was delayed this morning, and I'm glad to make it, and I appreciate everybody moving around. Okay, before I start, I just want to acknowledge that there is a war happening in Ukraine, and I understand that our minds might be elsewhere right now. And I want to acknowledge that this is a terrifying moment for many around the world, particularly for those who have family in Europe and Ukraine specifically. Okay, I also do want to share some work with y'all today that I've been fortunate to be part of. Much of this has been done in collaboration with trainees, and I plan to point them out as relevant. I hope to cover 4 topics today, starting with frameworks for assessing adversity. So after all, most definitions of resilience require that an individual experiences something adverse in order to be resilient. So I often hear people talk about resilience as though it were an internal characteristic. For example, he's a resilient child, and placing the ownership or expectation for resilience existing within the child. So thinking about this baby right here, what would make him resilient to adversity? So I contend that context is hugely important, and that in particular for infants and young children, it's their early caregiving experiences that are most modifiable and important predictor of their long-term outcomes. So I subscribe to a Winnicottian notion, which is there is no infant without their caregiver. And that if we want to understand children's trajectories, we need to be looking at the earliest years of life, when the brain is most plastic and receptive to the environment and to the relationships that shape that environment. That framework drives my broader program of research, and though I won't be talking about each area today, I encourage those who want to talk to me about pieces of these to find me afterwards to discuss, or find me on Twitter or email me. So what I'm really going to start talking about here is about adversity. So this paper was led by Kate McLaughlin, in which we summarized some of the various approaches researchers have used to examine adversity and potential mechanisms by which experiences of adversity get under the skin and affect different outcomes. So initially, most research labs were oriented towards studying specific types of exposure, for example, physical abuse or community violence. And labs worked kind of in relative silos, examining children who experienced one of these domains or on a continuum of these features. Another line of research has set aside this siloed approach and said, well, let's count up the different types of adversity that children have experienced. So this is a cumulative risk approach, in which regardless of the type of experience, the underlying belief is that it's through a shared global risk mechanism that these experiences might be related to negative outcomes. So you might be familiar with this, with the ACEs, or Adverse Childhood Experiences study, that's gained a lot of coverage and press over time. So this is a landmark study that found in a large sample of San Diego residents who reported on 10 different types of experiences in their childhood. And if they summed up those types of experiences, they found they were associated with a number of things in terms of later life outcomes. So not only things like mental health and depression risk, but also things like cancer and diabetes. And this was a surprise to a lot of people who weren't familiar with the importance of early experiences and the plasticity of the developing brain, making people particularly sensitive and susceptible to adversity in early life. However, as someone who's been interested in learning about what experiences are doing to a developing individual, I find this ACEs model to be incomplete. And it's likely that humans, like other animal species, respond to their environment based on what's happening in that environment. For example, receiving insufficient care, not having someone talk to you, not having someone play with you, sing to you, offer you hugs and kisses and comfort. That's going to do something different than experiencing unpredictable, chaotic, or stressful experiences. So in dimensional models of adversity, these different types of experience are grouped together based on what the likely biological consequence is for the person experiencing it. So experiences of deprivation are grouped together and then thought of on a continuum of severity from absent to severe. Similarly, threatening experiences are grouped together, so that lab that studies community violence and that lab that studies physical abuse might get together and say, let's think about these as like in kind and measure the severity that a child has experienced. And so that these might work together in some shared or global mechanisms, as well as specific mechanisms that are related to experiences of deprivation or related to experiences of threat. So returning to ACEs, there are some experiences here that align with threat. So I've highlighted them here. And then there are some that are aligned with deprivation, which I've highlighted here. And there are some that are harder to place. So for example, if one reports that their caregiver has mental illness, this was one of the original ACE reports, we don't actually know very much about what that child experienced as a function of them endorsing this. Maybe it was a short-term episode of postpartum depression that was fleeting and didn't have a big impact. Or maybe it was something quite severe and was associated with profound deprivation. Or maybe it was something quite scary and threatening for a child. So because the experience of a child can differ so greatly from endorsing this item, we don't really know very much about what a child experiences from this answer. similar with substance use. So this led me to think about the work of Yuri Bronfenbrenner, who pointed out that it's easy for us to measure a social address. It's easier for us to count up yes or no on these kinds of things, but it's not always clear that we know what a child experiences based on their social address. So I'll give an example here. So take poverty, which is not, by the way, one of the original ACEs, despite it being associated with a number of long-term negative health outcomes. This is a popular topic. A lot of people are studying poverty. You can define it in different ways, but I'll just say, for example, let's say we use a federally defined limit of whether the household is above or below the poverty line, and say, okay, this is my social address of interest. What do we know about a child's experience who falls below that poverty line threshold? Are they experiencing scarcity-related stress in their household? Maybe. Not all kids do who are falling below the poverty line. Are they experiencing fewer enrichment opportunities? Perhaps, but not certainly. And are they experiencing exposures to chaotic environments in and outside of the home? Well, statistically, on average, there's a link, but for any given child, this may or may not be the case. So the thing is, we don't really know by measuring these crude things what's happening in kids' everyday lives. And it can potentially inhibit us from understanding how different experiences affect long-term outcomes. The other question I often get is, well, don't all kinds of adversity co-occur? I mean, what's the point of thinking more carefully about the kinds of exposures kids have if bad things tend to go together? And it's true that, that we live in a society that there is historically marginalized groups who have disproportionate stressors in their lives. But it still may be the case that not all stressors are equally likely for each person who experiences any one type of adversity. So in order to address this question a little bit more carefully, I looked at different kinds of maltreatment experiences that people report. So this is a meta-analysis of population-based studies in which all participants completed something called the Childhood Trauma Questionnaire, in which 5 different types of maltreatment are reported using a Likert scale or continuum. And what we find is that, yes, on the one hand, all types of maltreatment tend to be positively correlated with experiences of other kinds of maltreatment, but there's quite a bit of variability in the degree or magnitude of those associations. And that some experiences that are alike, for example, physical abuse and emotional abuse, tend to go together more often, whereas experiences like emotional neglect and physical neglect tend to go together more often. Again, so this is, again, supporting the idea that potentially environments are set up in a way that's congruent with this idea that there are deprivation experiences and threatening experiences that may be separable. Okay. So I'm going to shift to neglect now. We actually have a long and robust literature on experiences of trauma, its effects, and its interventions. We tend to know relatively less about neglect, despite it being the most common form of maltreatment in the US. So some have called this a neglect of neglect. Okay, but it's a profound risk factor. And so one of the questions is how recoverable are children following experiences of severe neglect? Is it really, really a permanent damage, or are there things we can do about it? And this fear came from studies of orphanage-reared kids, so kids who were raised and grew up in a setting of institutional care. So in that context came the study called the Bucharest Early Intervention Project. It's the only randomized controlled trial of foster care as an alternative to institutional care for kids who were living in orphanage settings or institutional care. These are the principal investigators of the study: Chuck Nelson, Nathan Fox, and Charlie Zena. It started in the year 2000. It's been going on now for more than 20 years. I was lucky to come on board a little bit later on in the project, but I'm going to tell you about some of the original findings and some of our most recent work. So in this study, the investigators wanted to examine how family care compared to institutional care or care as usual for these kids in terms of their long-term outcomes. So they were 6 to 30 months at baseline. They were required to have spent at least half of their life in an institution, which is a highly deprived setting. Of course, the investigators thought, well, family care is obviously better than institutional care. This is going to be easy. But why do an RCT at all? So the goal of a randomized controlled trial is because there's random assignment to condition, we can be confident that if there are differences, it's a result of the intervention rather than a result of selection bias. So prior studies that had looked at kids who were in orphanages and kids who'd been adopted found that there were differences between these two groups, but they couldn't rule out the idea that there were selection effects, so that somebody who's going in to adopt a child would pick one who's doing better or has dimples or whatever it is that they're looking for. So this randomized controlled trial allows us to make causal claims about the effect of the intervention. So 68 kids were placed into a newly created foster care that didn't exist at the time in Romania. It was considered unusual to care for non-kin. So these needed to be created so that there would be people who would take in children in the orphanage. And then 68 kids were in the care as usual condition. They were not required to remain in institutional care. This just meant what would normally be happening. And as a result of this study, actually, many of these children were eventually placed into families through a government-sponsored foster care that was created after the initiation of the study. The analyses I'm going to show you when I compare the foster care group and the care as usual group are using this conservative design called an intent to treat design. So that means regardless of what actually happened, we're analyzing kids based on their original assignment. So some of the foster care youth were eventually displaced from their families and returned to institutional care, and some of the care as usual children ended up being adopted or placed into family care. So it's quite a conservative test. The other thing I want to mention is that the foster care is not just a regular foster care where we're trying to meet kids' instrumental care needs. The idea was that parents were supposed to psychologically commit to these children, to love them as if they were their own. They weren't temporary placeholders. This was supposed to be a lifelong commitment. So in addition to the two groups of children who were previously institutionalized at the baseline period, we included a never institutionalized community comparison group. So these are Romanian kids who were reared in their biological families, and they were included as a comparison group, but also because many of the measures that we used were not validated yet in Romanian. Assessments occurred at baseline at 30, 42, and 54 months, at which time the trial officially ended, and placement was then handled by the Minister for Child Protection in Romania. And then we conducted follow-ups at ages 8, 12, 16, and now 22 years. Perhaps the most famous finding from the study found that IQ scores were improved in the kids who were placed in foster care relative to those in the care as usual condition, and that the difference mattered based on the age of placement. So there was evidence for a sensitive period, such that earlier placements into family environments was associated with greater gains in IQ. However, the studies continued, allowing us to follow up these children as they reached early ages of adulthood. And this allows us to address some potentially relevant concerns related investments in early interventions. So, for example, some really promising early studies like the Abecedarian Project and the Perry Preschool Project each showed impressive and dramatic findings related to IQ or cognitive functioning as a result of their early interventions. But sadly, the large effects appear to fade out over time, leading some to question the value of investments in early care. So we had the chance to follow up, and we do another cognitive assessment in early adulthood. The kids are now 18 years old, so I shouldn't call them kids anymore. They're young adults. And we were able to see how are they doing now in terms of the standardized battery that's very consistent with their earlier assessments that were done at earlier time points. And here are the results of our three groups. So one thing I want to note is there's just dramatic variability within each group. But the other is that there may still be a continuing cost of exposure to institutional care in early life, given that the mean IQ scores for our two groups who experience institutional care are quite a bit lower than the never institutionalized community comparison group. However, I want to note again that using our conservative intent to treat design, we actually see a significant 9-point difference, which is a practically significant difference as well in terms of our foster care group to our care as usual group, which indicates that there is persistence of the effect of the intervention on long-term outcomes. What about those findings about sensitive period? Was earlier placement still associated with greater IQ? We do see a trend for this association that earlier placements tend to be associated with higher IQ scores on average, and this is again at our age 18 follow-up. We also found that placement stability was associated. No, I have to say this is setting aside our conservative intent to treat approach. This is really about what happened in the intervening years. So they're 18 years old now. What happened throughout their childhood? For those who were randomized to the foster care group, how many stayed within their family and how many ended up experiencing a placement disruption? And there's a dramatic difference in scores between these two groups. Now, we can't be certain that it's due to the displacement or stability. That being said, at age 54 months, when the trial officially ended, these two groups did not differ in IQ scores, which seems to suggest it's more plausible that it's the disruption in placement that may be responsible for these differences. Okay, so in order to scale up randomized controlled trials, it's important to know what aspect of the intervention is responsible for its effects. So it's us thinking about what's the active ingredient. And for us, it's obvious that placing children into families allowed for more opportunities for stimulating and nurturing care. Orphanages are notoriously depriving, and for children who are living in institutions, their opportunities for enriching interactions that are contingent and responsive are limited. So we tested whether caregiving quality was the potential mediator or mechanism of the intervention. So our study team recorded caregiving quality, or we coded caregiving quality from videotaped interactions that were recorded at ages 30 and 42 months, and masked raters coded them on a level from 1 to 4 here, where just the range is 1.5 to 5 for the quality of those interactions. And we expected that children who were randomized to the foster care group would experience higher quality caregiving interactions than those who were randomized to care as usual. And indeed, we found evidence there's a statistically significant and meaningful difference here, but again, note that variability. It's not that every child who's in a family is experiencing high quality care, and there's quite a few kids in the care as usual group who are having really high quality interactions during these observed videos. We then looked whether the quality of caregiving, and again, these are just snapshots of time from a video at 30 and 42 months on average, to see whether what we've captured just in that time is associated with later IQ scores. And we do see a quite strong association here. And the pattern is actually consistent with both our care as usual group and our foster care group. So even though there's a main effect, we see that pattern within both groups. We then examined whether there was a mediation, and we found that caregiving quality in early life explained half of the variance of the intervention effect in IQ, giving us more confidence that it's very likely to be that improved caregiving quality is how our family placements improved kids functioning in this domain. Okay. So this is a lot about kids in orphanages, and there are millions of orphan children around the world, so this is a real pressing public health concern. However, I understand we're in the US, there aren't that many orphanages here. Is this even relevant to the kids we care about here, for example? So I think it does still have relevance. And in part it's because we don't really know very much about the relative consequences, about the range or continuum of experiences that children have, ranging from neglect to enrichment. And so here on the x-axis, I've plotted that continuum. And on the y-axis, I've called this broader construct of healthy development. And so prior studies that have tended to look at this child was neglected or not, or this child was raised in an institution or not, use this threshold approach to examine the potential relationship between things like enriching experiences and healthy development. Others have considered a more linear model where experiences of greater stimulation and nurturance and enrichment is associated with better outcomes on average. I think that's plausible. There's a third model that may more accurately represent the associations here, which is a diminishing returns model, which is to say that the per increment gain in healthy outcomes by shifting kids at the lower end of the continuum may be greater than targeting kids who are at the higher end of the continuum. This is just a theory, but unless we're testing it, we won't really know about where we should be investing most of our dollars in terms of policies. Okay, so what do we know so far? So stimulating and nurturing care can buffer children from adversity, and I would contend they serve as the foundation for learning and emotional health. And so I'm going to show a few studies about how we tried to trace differences in environmental enrichment in community samples. In this first study, led by Lucy King, we followed families from when their children were 6 months of age until they were 18 months of age. And at 6 months, they were wearing these Linas, which you've already heard about today, so I don't have to spend any time explaining that. But they, in addition to the recordings that they get from all day, we wanted to look at the 5-minute segments in the recording. So how many of those segments was an adult detected as speaking on it? So 1 or more words. It's not about the amount of words a caregiver said in the recording, but just was a caregiver detected on there at all, yes or no? And then we wanted to see, is there an association between how consistent or how available a caregiver is on these day-long recordings with mental health? So this is early symptoms of psychopathology at 18 months. And you may be saying, 18 months, isn't that early to be assessing things like psychopathology? I'm an infant mental health psychologist. My area is 0 to 5, and indeed there are really strong ability, there's a strong ability to be able to detect individual differences in things like temper tantrums, crying, negative affect that go on to be consistent with what we traditionally identify as mental health disorders later on. And what we see is that kids who have more consistent or available caregivers as detected through the Lina tend to have lower symptoms of psychopathology a year later. And this is just a day-long recording, but consistent with Kaya's work and others, it seems to be telling us that there's really something we gain from looking across the day, because when we put this in a model with our really carefully and labor-intensively coded sensitivity measures and warmth and so forth, those didn't predict anything like this. So it really told us that we're going to get something more from assessing kids in their real environments. In this same sample, this is a project led by Dr. Virginia Sallow, we examined whether features of a child's environment also captured through the Lina were associated with the child's later expressive vocabulary. In other words, how many words they knew at 18 months. And what we found was that while there is an association that's small between infants who initiated conversations as recorded on the Lina, so infants starting a conversation with their caregiver, they tended to have higher expressive vocabulary. That makes sense. Maybe just really talkative babies, that's an individual characteristic that we're capturing. But more interesting to me was that we found a stronger relationship between adult-initiated conversations, so that babies whose caregivers initiated more conversations with them, those babies tended to have stronger expressive vocabularies at 18 months. Now, this isn't genetically informed. We can't say it's causal, but it suggests to me that these interactions that kids are happening in their everyday lives are important across domains for emotional functioning, like symptoms of psychopathology, but also for things like expressive vocabulary that are relevant for school performance. Okay, in one attempt to better understand the association between children's environments and simulation, this project led by Lauren Malachowski, we used text messaging to reach caregivers of 4 to 6 month olds throughout their day across 3 days in which their baby was wearing the Lina device. And we asked at each one of those text messaging sessions, where's your baby right now? Are they in a crib? Are they in a pack and play? Are they in a bouncy seat? And we coded each one of those as to whether they were an infant seating device or infant equipment or any other location. And we also asked if the baby was asleep or awake, and we excluded all those sleeping reports, and then paired up the data that we got from whether the caregiver reported that the child was in a device or not with the same time on the Lina on how many words were in that 5-minute segment. So it's not a perfect approach to know how many words are spoken when the child is in a device versus not, but it gives us a sense of what's happening. And we can look at this within a within-subject approach. So for babies, when their parents report that they're in a device versus not, are they hearing fewer words during those times? That would make sense. A lot of times people say, I'm cooking something hot on the stove. I can't be carrying my baby right now. I'm going to put him in this safe place. That makes sense. They might experience fewer words during those times. But maybe cumulatively, on average, across the days, those kids who are spending more time in seating devices may experience fewer words. So we just wanted to see if that was the case. And what we found was that, yes, within children, they experience fewer words when they're in seating devices or when their parents report that they're in a seating device. So about half as many words they are exposed to when they're in seating devices. But that might not matter. Again, it could just be a temporary thing. But what we found is when we looked across these 3 days and the proportion of times that parents reported their child was in a seating device when we checked in those 36 times, we found that those who reported their child was more often in a seating device experienced fewer words across those 3 days on average. So this is striking because it holds even when we covary for all sorts of other things we think are associated with infant language, including the infant age, number of people living in the home, years of maternal education, sex of the infant, presence or absence of adult siblings. So it seems to suggest that, that this might be an important feature of early environments that we could target if we were thinking about shifting kids' experiences. Okay, so our take home from this line of work so far has been we need to be better assessing kids' naturalistic environments. Demonstrating this figure, this might be captured through video in some ways, so we can tell through video if a baby's being touched or held. In short-term recordings, we can see how far away caregivers are from their child. It's in close contact that we're more likely to have those kind of stimulating and enriching and nurturing interactions. But it's really hard to put a video camera in everybody's home and everyone's angle. There's lots of privacy issues about that. And it's just, it would be infrastructure intensive to be able to do that. So I've been thinking more about how do we solve this problem of studying kids and caregivers in their everyday context. And just like you all, this interdisciplinary group, I was really lucky to find some engineers who were interested in this problem as well. I'm not an engineer, and so I really relied on expertise, and it's actually multidisciplinary engineering team expertise. With the help of the Jacobs Foundation for Funding, we developed something called a tot tag. So this is a wearable device that can dynamically and unobtrusively capture physical proximity in real time between any two individuals who are wearing those devices. And it can capture, for my interest, caregiver-child relationships, but you could imagine this could be used on any dyad or any set of individuals throughout their day in their natural context. So these devices are designed to monitor and then extort proximity between infants and caregivers over time. Close measurements may indicate opportunities for more direct interaction. More distant measurements could indicate that the caregivers may be in the same home or building, but not directly interacting. Because they're infrastructure free and portable, they're not reliant on just being in the home. They can be wherever the dyad goes. That might be to the park or grocery store. And we're not just giving these to parents, we're actually giving them to all the caregivers in a child's life and siblings. And so we can look at different relationships between them. So we've really just been in the phase where we're testing this out a lot. So just like a lot of other psychologists, I use my own family to do a lot of our studies just to test them out. So this is me recording our adventures of trying these out on a much warmer day than it is today here in Austin. And there's just various activities that happen. My kids spend a lot of time together. And of course, we were doing this all during the pandemic. And this was a proof of concept. Just, can this work? Can we get some data from this? I know a lot of you are in similar stages with your projects. Can we get something here that's telling us this is promising? And we were able to turn this into a paper that provides support that this might be a really useful tool for measuring caregiver-child interactions. So I'm just going to show you a little bit of data from that paper. This is in one family, this is like my family, my contact with my daughter during the day and my and their dad's contact with her during the day. And this is the same with our son. And so you can see there's just so much variability. So when the lines are very short, that means the two are close together. And when they're more distant, that means they're in range but far apart. And then when you just see a white space, they were out of range from one another. So there's a long nap time for my son in the middle of the day, which is why that part's missing. This was replicated in another family with an infant child so that we could see just some idea that there might be differences between families, maybe as a function of developmental stage of the baby, for example, that are promising. The other thing is because different measures of environment may be doing different things for the child, so being held and being touched might mean something different than being talked to. We wanted to see how related are our measures of physical proximity with adult word count picked up through the LENA. So we had them wear these at the same time. And what we found was a statistically significant but pretty small correlation between the times where caregiver and child were in close contact and the amount of words spoken. So yes, on average, there was more female adult words detected on the LENA when mom was in close contact with her child, and same with male adult words when dad was in contact. These are not perfect algorithms, but they do give us a sense that yes, there is something here that makes sense, but these are not interchangeable markers of the environment. Okay, so how can we tell if experience matters? What are the types of child outcomes that would be most useful to understand the potential impact of early experience? So I'm actually just going to shift now to some future directions. I don't have a lot of findings left. This is just kind of where some of the directions are in my lab right now. So one is to try to capture early brain development. So what we found is that it's actually a lot easier for us to get newborns into our lab if we actually recruit them when they're not yet born. So we bring in people who are pregnant into our laboratory, and we get to know them. We ask them a number of questions about themselves. This was not the plan to really study people who are pregnant, but now we actually have tons of data on pregnancy. So anybody who's interested in maternal mental health, come find me. And then once they're babies due, we invite them in for a non-invasive imaging procedure. So this is an MRI study. It's, we do this during natural sleep. So we wait till babies fall asleep. We use really good hearing protection. If anyone's had an MRI, you know it can be loud. And so we put lots of hearing protection on so babies can stay asleep while we take pictures of their brain. And the goal was to try to understand how experiences that kids have may be shaping their brain. But what we found is that there are already so many differences at baseline. So when children are born, their brains vary in all sorts of ways. So in this work that was really spearheaded by Kat Camacho, we looked at whether prenatal stress exposure, so people's reports of stress during their pregnancies were associated with functional connectivity between emotion regulation regions. So this is amygdala and medial prefrontal cortex. We looked at this during a resting state scan, as well as through white matter tract development with a diffusion weighted image scan. And what we found is already that there seems to be some association between prenatal stress and developing emotion regulation circuitry, which we can keep in mind as we look at how the postnatal environment further shapes the brain. So this is an example of the same baby scanned twice, once after birth and once again at 6 months. And you can already see there's really dramatic changes happening just in these first few months of life, which makes this a really ideal opportunity if you're interested in seeing how the brain is responsive to the environment to be studying the brain. Okay, and so we have a grant from the NSF that will allow us to measure how caregiving experiences are associated with these changes in emotion regulation circuitry and other brain regions of interest. Okay. So what are the implications of what I've shown you so far? So experiences of adversity are associated with functioning much later in development, that early life is a period of increased vulnerability and opportunity, and that positive interactions with adults can mitigate the effects of adversity. So I like to translate, if I can, a little bit back to policy and practice. So I'm a clinician by training. I'm not doing any clinical work now, but I remember thinking at times if I saw a new family, what level of intervention do they need? Where do they need support? And then working with community agencies, so mental health agencies, or at a county level or even a national level, what are the kinds of treatments or resources we want to have available to support families, particularly those who've experienced adversity? So I worked on this paper to try to identify a framework for identifying for particular cases or for particular contexts, what's the order in which we might support families and what things should we have on the menu in order to do that. So at the first level, it's just very basic. Does the child have a caregiver or not? And so if this is where you are, this is the first thing to address. And the intervention is family placements. Okay, so this is the first thing to do. Second, is a caregiver consistently available or inconsistently available? So there's a variety of things that may affect caregiver availability, including chronic substance use, having to work 3 jobs to pay the bills. Those kinds of things can interfere with being consistently available to a child. And so at a policy level or at a practical level, the intervention strategy would be things that target that. So substance use treatment programs, violence prevention programs if there's violence in the home, or policies that make sure there's a living wage for our families. And at the third level, so once we have a caregiver, they're consistently available, do they actually know what to do? Do they have the tools available to respond in an effective way to help regulate their child? And so there are third line interventions here, or the third level 3 interventions here include things like biobehavioral catch-up, child-parent psychotherapy, PCIT. These are kinds of interventions that are designed to help support families that are already there, are committed, and just need the tools to help do it. And so if you're a practitioner, you may be thinking, what tools do I have in my toolbox? Where can I find community supports to be able to support families wherever they are on this need? Okay, that's it. I want to thank you all for being here. I want to thank my funders, my lab, and this little image I have up here is just to really communicate that it takes a village to raise children, and so everybody's playing a part, and you may or may not already know what important role you play in children's lives. So thank you for doing that. And just one final thing, I just want to note that I've been following the news about the law here and the requirement that families report children who are trans, and I just want to say that's a terrible idea. I know probably most people in the room here agree with that, but if we're really thinking about supporting families, we need to think about how that's really dangerous for kids. So, okay, thanks.
We have time for questions, and there are microphones, I think, around, if anyone has a question for Dr. Humphries. Huh? Get on the mic, okay. We have time for questions. That was an amazing talk. I feel like actually worked really nicely having the lightning talks first, and then I can see how a lot of the different pieces that we're working on, you also are pulling together into your research. So that was very exciting to see how aligned those things were. Yeah, question.
Yes, so I'm an engineer, so that means I know nothing about this. But one thing that struck me with the, what was it, the child tax credit, whatever it was, that was lifting a bunch of children out of poverty, has there been studies just on, you know, a lot of the, you know, working 3 jobs, the stresses, et cetera, a lot of those can be, you know, if you have, you mentioned a living wage or whatever other financial support. So what's your thought on that as a across-the-board intervention that might help address some of these issues?
Oh, thanks for that question. So some of you probably already know that there's a group of people who are studying this in an RCT design through babies' first years. And so Kim Noble's one of the lead investigators on that project. I'm not involved, I've just been following it. And in that RCT, they're giving families either a minimal amount, like a small amount of money per month, or a larger amount, and trying to see exactly that. Does giving families more money, does it change kids' outcomes? I don't think I'm going to be out of business thinking about caregiving as a tool, an important thing in addition to financial support. I don't think it's just one or the other. I think both are really necessary. I think there are a lot of financial related stressors that can impede even the best caregivers. And as Kaya's students shown earlier, you know, people vary so greatly. There's some work by Monica Elwood Lowe that finds that at the end of the month, before people have their monthly paycheck, the word counts detected on leanness tend to go down, which seems to suggest that financial strain and stress may be associated with the kind of quality care that kids are getting. And so taken together, I think it's very likely that things like improving the financial resources that families have is going to be a net good for everybody in that family, including the kids, but there are probably still going to be needs for additional supports for being the effective co-regulator, especially in times of distress that are not financially related.
So it's someone who's easily excited about smart devices. So I have a question about the wearable you used together with Jacobs.
Yeah, they say Jacobs, but some people say Jacobs, yeah.
Okay, with the Jacobs Foundation, because I know there are certain other commercially available wearables that will also provide information about indoor co-location, even outdoor co-location. They're worn differently. Some are worn around the neck, and I'm just wondering what went to your group's decision to use this particular wearable device from Jacobs Foundation. Is it because the technology is used, or the way it's worn, or any other consideration? I'm just curious. Thank you so much.
Sure, thanks for that question. So Jacobs just gave us the money to do this, so it's not like their device. But what happened, I was a postdoc at Stanford, and I was like living in Silicon Valley, and I was thinking, gosh, there's got to be tech already that can do this. You know, I just need to find the right one. And I learned a lot about, more than I ever thought I was going to know about different technologies. And so we thought, well, GPS might do this, but GPS doesn't have the fine-grained kind of, we can get, you know, within centimeter accuracy with this. There are like RFID things, but they're binary. And so this is using Bluetooth. We can, SOSA track system is what the engineers are calling it. Everything's available on GitHub, so you can read all about it on our GitHub page. It's all freely available. If you wanted to like make these devices and use them yourself, you'd be welcome to. So everything's available there to do it. The real hiccup right now is just there's a chip shortage, the global chip shortage. So we haven't actually been able to buy any more devices. We keep kind of fine-tuning and making different iterations of the board. So we're on revision H right now as we find different tweaks. So we've built in a real-time clock so that we always know what time it is, because anytime the battery ran out, we would lose the time. So, we've been learning a lot as we've been trying to program it. The main goal that we used this tri-point chip to do it. It had previously used by Praval Dutta's lab at UC Berkeley, which was all face-to-face detection. And so it's the same board, but we've made it so that you don't have to see anybody. So that really was important to me, because sometimes you're holding a child, you're not face-to-face, their back is to your chest. Those kinds of things we wouldn't be capturing with something like the OPPO. But Pat Panuto is one of Praval's grad students, now has their own lab at UC San Diego and has been helping us to do this. So really, it was naivety on my part that this was actually something I'd be able to do easily. And then once getting some funding to try to do it, feeling like I really have to follow through and deliver. So that's been our process. We are really excited about the potential that this could be useful in a variety of research programs for people who aren't just interested in parent-child interactions. And our hope is that eventually that it'll be easy and cost-effective for people to integrate this in their research. And we're really excited to be able to make that available to other people when we've got this chip shortage thing worked out. What?
He asked what's the cost per device?
Yeah, right now it's about $200 per device.
Excellent presentation, by the way. I've learned a lot from you. And speaking of resiliency, I'm curious to ask how much of an influence does parent and child communication influence the development and the, I guess I want to say the enaction of resiliency? I don't know if you've touched on that or not further, but I was just curious to ask.
Yeah, so I think part of it depends on how we define resiliency. And so a lot of times people say, are you functioning kind of at or in the normal range despite experiencing some form of adversity in early life? What we found actually in our studies from the Bucharest Early Intervention Project is that even when we do those assessments at one time point, a child who's functioning resiliently or adaptively at one time point isn't always functioning that way in the next time point. And so there's such variability in and out of what we might consider adaptive or resilient functioning. And so I think it's very likely that caregivers play a big role in that, especially in early life, that feeling like I have someone who I can trust, who's there for me, that is interested in me, who delights in me. Those things are really important for fostering good mental health and school performance and other things. As kids get into adolescence, in some ways, the role of the parent is still extremely important, but it may become less important as the role of peers and other kids in the child's life play a role. And so while I still think having that secure caregiving relationship can buffer kids from adversity during that time point, there are other sources of variation that may be relevant to play in. But I think, being talked to, being held, being told, I love you and you're great. I mean, those are the things that every kid should be hearing. And I think those are the things that are most likely to promote resilient functioning despite adversity. And being able to say, especially if the trauma happened within the relationship, to be able to say that out loud, to acknowledge that was a mistake, to apologize, and to rebuild that relationship for repair is really important.
Hi, wonderful talk. It was really interesting. One thing that I was curious about, and I know this is probably in the future as you use this device, but have you considered how to, like, if there's going to be a ceiling effect for the amount of people in proximity with the infant, or like how to handle that, like how many people are in the household, and whether or not, in the same way that with language, if it's yelling versus positive, that can change how effective it is. Does the amount of people in proximity to the infant affect that?
So, sorry, is your question like how many people can we measure at once? Or is there how would we operationalize how much is too many? Or?
Yeah, so I was thinking more, I guess, theoretically, like how you would kind of, like, is there going to be a ceiling effect eventually, like it's not helping the kid anymore to have more people around them, and how you would handle that in future research?
I guess one of the cool things is that we have no idea, like we have no idea at all if like there's a certain amount that's good or not good, or what the shape of the relationship is. Like I would assume that having some close contact is better than none, but that's why it's so interesting to know, like, what's that shape of the relationship like? Because you could imagine that, like, if you have a child who's in close contact with their caregiver for 8 hours a day, and then you boost it to 9 hours, like, are we going to see any differences? My guess is probably not. But if you have a child who gets 0 minutes of close contact with the caregiver, and you give them a whole hour every day, you're going to see dramatic gains. So this is my idea, is that I have reasons to think this is going to be important. It may matter about the quality of the care that they get with each caregiver. So let's say you have a really high quality caregiver who's really responsive and sensitive, but you don't spend a lot of time with them. And then you spend a lot of time with kind of a less responsive, less sensitive caregiver. Those are the kinds of things that I think are going to be really interesting to know, kind of the balance between quality and quantity, what's enough, what's associated with better outcomes. I think this is going to be like many people's careers to answer. But the other thing is that we can have like 200 of these devices all talking to each other at the same time. So we can put them, like, we could all in this room be wearing one right now, looking at our relationships in terms of physical proximity to one another. So it does allow for us thinking at the dyad level, and also for one individual, what's their relationship like with everybody else who's wearing a device. And so I think there are like so many ways that you could take this.
Okay, thank you again to Dr. Humphries, and we're going to have closing remarks from Francis Champagne.
Thank you, Catherine. Thank you, Sarah Kate. Thank you, everyone, for today. I think the talks really gave a wonderful overview of the scope of this initiative. And I think one of the grand challenges of this grand challenge, certainly in the early stages, was really trying to create that dialogue and communicating across disciplines, which are well represented at this session today. But I feel now that when I hear about, Bluetooth, use in social behavior and communications and all the different topics that we came over today, it's kind of a natural part of the work that we do. So congrats to you all for all the wonderful work you do, and I think it was wonderful to have Catherine illustrate how other people are integrating technology and these questions into their work. And, and thanks to our community strategy team, who I think have really been an anchor for our initiative. And I would say, for me personally, I think that is where I get a lot of the most fulfilling information and interactions, because I think that's where the science and the approach that we take can really fundamentally change. So thank you to all. I think this is mingling time, so to this extent. And it is nice to see everyone, because I think it's really been 2 years of Zoom. So thanks for being here.